Welcome everyone to today's webinar. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar preparation of materials can take some time. Our speakers for today's program are Matt Savelli, Senior Director of BPCI Advanced Program, and Dr. John Tessier, Orthopedic Surgeon at Signature Medical Group. At this time, I am pleased to turn the floor over to Matt to begin today's presentation.
Thank you. So welcome everyone. Thank you for taking time out of your day to attend this webinar with Dr. Tessier and myself. We are from Signature Care Management, which is a division of Signature Medical Group, and we will jump into our topics for today. So briefly, we just wanted to give an overview of some of the topics that will be covered on this webinar today. We will go over our experience as a convener in the first BPCI program, as well as moving into BPCI Advanced, and also cover a variety of topics that we feel are key strategies in order to be successful based on the lessons learned from participating as one of the original conveners in the current BPCI program. Just a back overview of who we are. Signature Medical Group is a multi-specialty physician group with more than 160 physicians and we see over 500,000 patients annually. We are one of the original awardee conveners in the CMS's Bundle Payment for Care Improvement, or BPCI program. We're currently one of the largest orthopedic bundles. We currently manage one of the largest orthopedic bundles, and we are the only physician-led convener participating in the current BPCI program. As we'll get into later in the webinar, we have developed an in-house system, Mosaic, which helps support organizations like yourself who are interested in pursuing bundle payment programs both at the government and commercial level. A little bit about our awardee convener scope. Currently, in the current BPCI program, we convene for groups in over 27 states. It's about 55 practices with 45,000 annual episodes. It's about 12,000 physicians across the country in 385 hospitals. This just gives a little bit of the scope and size to the current program in which we partner with physician groups and hospitals around the country. And we really thought it would be a good idea to just give a little bit of a historical overview of Signature Medical Group. And I'm going to turn that over to Dr. Tessier to talk about how Signature Medical Group was founded.
Good morning, everyone. Welcome. I am a orthopedic surgeon, somewhat of a Jesuit product, having attended Marquette University, Creighton University, and St. Louis University. Signature was really started as an orthopedic private practice. Probably several of our practices here in St. Louis came together. I've been working here for over 30 years. I do perform adult reconstructive surgery. And so after 2000 to early 2000s, Signature Medical Group was started. And now we really, as Matt said, have gone from our administrative folks building and trying to support other private practice institutions in terms of their productivity. We now have, I think, approximately 63 orthopedic surgeons across the state, St. Louis to Kansas City. We have over 40 OBGYNs and other primary care, general surgery, and such. And so it was really our administrative capacity that started aiding private practice physicians that really got us, headed in towards the direction of putting together this multi-specialty physician group. I'd say our journey started with regard to value back in 2007, 2008, when our administrative team started looking at specific orthopedic episodes of care. At that time, we worked with a labor union locally that was interested in population health and reviewed the claims data on 50,000 covered lives to really evaluate our group's performance with regard to quality, cost, and outcome data. At that time, we discovered that Signature Orthopedics in the St. Louis market was 40% less expensive while providing the same or better outcomes on the subset of musculoskeletal patients. So as we have had more and more interest and engagement in looking at ways to lower cost and maintain high quality with additional providers, our organization really saw the move in healthcare, particularly with regional, national business health coalitions who were bringing to bear concerns about cost and cost escalation. They were demanding these changes towards value, and I think that really made us, take a look at our own strategies, realizing that declining revenue for surgical cases, we couldn't make that up with increasing volume. That just wasn't sustainable. So our early interest in tracking our cost and measuring quality became a focus of our practice. I think that most physicians, when they are faced with looking at their own data, they have a impression, it's not unique to orthopedic surgeons, and they consider themselves high performers. I think when we all looked at our data, it was pretty revealing and eye-opening because we were all not high performers when it came to value, and there was a big variation. And as I'm sure many of you know, when you start, drilling down into orthopedic service lines, it's this variation in cost that is so challenging to try to diminish that amongst providers without compromising care. So I think more and more as physicians and our experience with this bundle and working with these 1,200 physicians and trying to help them evolve into this understanding, this process, I think when they realize and stop and think that they're being profiled by insurance companies, by ACOs, by CMS, by U.S. News and World Report, there's going to be more and more transparency and multiple people looking at their personal clinical outcome and performance. So this adoption and this understanding, this is not an overnight process. This relationship with these physician groups is a significant deal, and it's a significant challenge to go through this adoption protocol. And ultimately, I think once you engage with this and work at it and really see what can happen personally, I'll talk about myself a little bit here. I think you hit a tipping point with patients where you see the patients are happier, their experience is better, they feel like they're really cared for by your practice, and their outcomes are better. And so I think it starts to get a life of its own and really blend into your entire practice, not just your Medicare patients or elderly patients or BPCI patients. So we use a lot of the patient reported outcomes to drive our clinical care and better understand our surgical interventions. That helps us with our perioperative adjustments for particular patients with particular disorder to try to really make this a patient-centric process that we've helped to develop here at Signature. I really think the strength here with the Signature team is the capacity to relate individually with these doctors. And I think that we've put together a great team that's really centered on, collaboration, to not have a cookie cutter approach and not have a situation where, this is a dictum from an insurance company telling doctors how to practice. These are talented surgeons in this country with tremendous training. They're 90th percentile individuals. If they had decided to go into finance, they would have had GMAT scores over 700, most of them, and they'd be in the top 12 MBA programs. They are driven, they're skilled, they're committed, they're hardworking, and so here they are, find themselves as surgeons, and so it's challenging when all of a sudden outsiders come in and start giving them direction about how to practice medicine. So I think the impact of our physician-led team and the integration of our entire coordinated group of talented people from our regional case managers throughout really can help a busy practice transform to start working smarter, not harder. And when we really look at our team, I mean, Matt, you're with these people every day that we've kind of put together a lot of different experts and talent. We're not a managed care company. We're not an insurance company. I mean, the physicians are in exam rooms every day with patients and families, just like our doctors were convening for. We're not a Wall Street-owned company. We don't report to stockholders. We don't manufacture or sell orthopedic implants. At our core is really the physicians interfacing with our organization of talented folks that Matt leads this group, and this has an immediate impact in delivering our services to our clinic and office settings, impacting our nurses, our PAs, our nurse practitioners in providing coverage with the case manager that's working with our practice. Matt, you probably want to speak to some of the team that we've assembled.
Yeah, so when we started this program, we quickly understood that there was going to be an infrastructure build that was going to be necessary to be able to support all the practices that chose to partner with us in this initiative. So you can see on the right slide, from a signature care management perspective, the infrastructure that's in place that it took to be able to put a bundle payment program like this together and be able to have the success that we and our partners have achieved to date. And those components are everything from account management to legal to compliance, but really the core is our regional case managers, our telephonic case managers, and how they drive the physicians to help perform care redesign. You know, lately in healthcare, especially over the last 5 years, it seems that there's a lot of buzzwords that are going around. One of those buzzwords is integration. But really, when you think about what integration and in order to integrate means at its core, it's taking individual parts or components and being able to successfully align or combine those into one achievable whole part. And that's really what managing a bundle payment program is all about at its core. It's looking at the individual parts of healthcare as they existed traditionally and trying to put together a process in order to eliminate waste and improve patient outcomes while also aligning community resources such as the hospitals, the physicians, the skilled nursing centers, therapy centers, home health organizations, all working together in order to achieve the best possible individualized care for each patient that enters an episodic care management model. Signature as a convener has had tremendous success in the first BPCI program in partnering with the 55 groups that we've worked with around the country. One of the things that we are very proud about is that although we've reduced unnecessary post-acute utilization by looking at individualizing care plans for each patient, which Dr. Tessier will get into shortly, the great thing about that is the outcomes of the beneficiaries has increased dramatically from the baseline period through 2016, 2017 data to be able to support reductions in readmissions, reductions in DVTs, reductions in infections. All of these things come from integrating care and putting individualized providers together in a community trying to achieve what is the best case scenario for the patient.
We're speaking with you today from Missouri, St. Louis. I think most of you will recognize Mark Twain here. I think this just makes me think about the orthopedic surgeons that are providing care out there. I think Mark Twain was famous for one of his sayings was, "I'm all for progress as long as it doesn't require change." And I think, physicians and surgeons have gone through years of training, and they've had outstanding mentors from across the country and the world, many of them. They're skilled in what they've been trained, and they very much believe that what they do is right and the best. And so all of a sudden when they're approached with a new philosophy and someone explained to them that healthcare delivery is changing and now they need to streamline their office protocols, they need to change what they're doing every day in their clinic, they need to change their OR processes, and maybe some of them use drains or a cell saver or Aquamanus or various things in the OR that are expensive, and now all of a sudden is some person in the operating room wants to streamline these cases and impact the post-operative practices and have an effect on this. And it's hard for these surgeons to all just act like, well, we all do things the same and this is very easily done. So any administrator who's tried to coordinate a service line care path knows that getting physician consensus is easier said than done. Our ability with our team and the integration and collaboration of our team puts us in a position to treat physician practices uniquely, and physicians within that practice are unique. And we have practices where the first thing out of the busiest joint replacement surgeon's mouth is, I do 500 cases a year. I want to talk to an orthopedic surgeon who does the same amount of work that I do because that's the only guy that's going to understand my issues. Okay. That individual is very different than a young, fellowship-trained, talented doctor who now is a hospital employee, and he's entered this world right now, and all of a sudden someone's laid this value equation on him, and he has no experience within this, no thought about this. He's thinking about his future and his practice. So this is new world, and so the approach to these doctors is very different. And then you have, to add to the complexity, you have a hand surgeon who's busy, working in a surgery center and doing multiple cases and complex things, but his group still has him taking call. And so on Saturday night, he's taking care of femoral neck fractures and he's doing hip prosthesis on the weekend, and that rolls him right into the bundle. And his performance as a hand surgeon doing call duty to help out his group can have a major financial impact on the group's performance within the bundle. So this cannot be a one-size-fits-all approach to these doctors, and I think that's part of the whole behavior process that's unique to all of us, our ability to grow into this adoption of understanding this and trying to make it work in our within our practice. I think that when we look at this cultural shift of where we're all trying to go, before BPCI, there was fragmentation of services and care, which was adding to a lot of cost. And obviously everyone listening here has some interest in seeing the Medicare Trust Fund continue to be solvent as we all age ourselves. But there was never any training or any incentive for this collaboration. It was very much siloed care, whether you worked for a hospital or you were in private practice, you dealt with consultants, you dealt with the preoperative anesthesiologist. These are all very unique and different things. Obviously, in our practice, I think here in St. Louis, we've got 26 surgeons, orthopedic surgeons here. We did not have a social worker. We didn't have people looking at case management and interfacing with these patients. We just, a lot of practices have two kinds of patients, pre-op and post-op. The patient comes in and they have arthritis and they're having trouble and they have a bad looking x-ray and they're miserable, and the doctor says, I've got room on my schedule Friday, let's do a hip replacement. So I think that this cultural shift where we're engaging the patient up front, we're really understanding better because we have a set of resources that allow us to interact with the patient, set expectations up front, modify their behavior and some of their medical comorbidities, puts us in a position that we can eliminate or minimize the variation amongst providers and meet or exceed benchmarks and provide safer, better care. This is just going to lead to better patient satisfaction and from their perspective as well. So, I mean, that's really at the part, I think, that's Signature's strength in terms of delivering is this change and variation where there's much more attention up front to setting expectation and really evaluating the patient to make them as safe as possible for a procedure. The physician role we've, alluded to. They're going to be the ones that are going to build their own protocols and not, sort of be told. They need to sit down in a group, and they've been doing this for years with regard to management of their practices, management of their call schedule, financially what they're doing in their practice and, care opportunities and morbidity and mortality. They've had these meetings, and so their engagement and discussion about joint replacement protocols, what the team is going to set in place with regard to these high-risk patients and how they're going to manage them, what the structure, and this I think is where Signature is really powerful, going out and putting together a team that can interface with post-acute care centers. Let's figure out who the 5-star providers are. Let's have a solid relationship with them so we actually know where our patients are going to go after surgery when they need that level of services. So, getting a physician to engage, looking at monthly data. We have a tremendous data feed that we receive from a CMS, and I know Matt's going to discuss that more together as we talk about some of the technology that our analysts and people have put together. But that whole using the power of the data to really impact your performance and how you manage these high-risk patients can become really powerful. So that relationship and your willingness as a surgeon to communicate with a caseworker, it's not something you've ever done before. It's not something that you've had to, text your caseworker on the weekend when you have someone with a broken hip and say, this patient may be in the bundle. I don't have time to check it out. Please check it out. And that kind of communication with an internal RN case manager, that leads to better care, but it's also critical to the physician participation. What's really strong and powerful in a group is we know if we can figure out who really has the position within a practice to become a champion for this program. We work with all kinds of different practices. Some of these practices don't need a champion because they'll have 9 guys that perform arthroplasty surgery, and they can all sit down and agree and do things how they want to do and really make some headway with regard to data review and performance review. But in a lot of practices, working with somebody who's a trusted member of the practice, who is passionate about outcomes and quality, someone that's a high performer and can be very honest and transparent with the other surgeons, engaging with that person and let them become a leader with regard to this outcomes data, that's a critical piece of this, because there is ongoing data, there is ongoing ability to look at past performance, learn from where we all thought we were doing so great and all of a sudden, well, maybe we weren't, and how do we change our behavior? That leadership is key, because most of us have not had experience dealing with risk. And this risk is new, uncharted water for us, and our behavior is having an impact on financial risk for the practice. So having a watered down policy or watered down clinical thresholds that there's no teeth in that for the surgeons to really believe we're going to follow this, that's really the only way to make the program impactful. I think at the heart of care redesign is the case manager. And this role frequently nurses or nurse practitioners or physician assistants. These are the powerful top of the license performers that I think I see as difference makers in our practice and the practices that we work with. So many surgeons are very busy. They have an office full of patients that are just crazy and out of control. They hear about trying to re-engineer care and they scratch their head and say, I'm too busy for this. And some of those individuals need to understand what's at stake, need to understand what the financial opportunity is. And then part of our team's process is, let's build a support network with our regional caseworkers to empower your talent that you'll have in your practice to have these interventions with your patients up front. And I think once the providers can kind of see that it doesn't mean I'm spending an extra 45 minutes with a patient trying to plow through all these questionnaires and data to kind of understand, what their history of how many falls they have and what their functional capacity at home is and what their, preoperative pain scores are and how, just, on and on and on. The analysis of this is significant and time consuming, but I think once the physician realizes that there's going to be some re-engineering of care, the case manager is really the key to this and really the engine that drives this. And so I think that that coordination from the caseworker, not only dealing with the surgeons that are performing the work, but I think the thing that has changed also is our relationship with the hospitals. These aren't just our workshops where we show up. This is where our patients are. We depend greatly on their talented staff and the care that they receive. These programs that we've put together, create thinking about, let's revisit your discussion with the case managers. Let's go talk to the discharge planners. Let's go rethink how post-acute care is assigned and who gets that and who has that conversation. We've maybe never had a caseworker in our practice, and so the last thing that happened was, where's the patient going to go after surgery if they couldn't go home? And that's something that just kind of happened because typically the surgeon was so busy, he'd go back to the operating room and operate on somebody else, and the family and the hospital case managers, made the call on this. Now, these discussions are happening way up in front in the preoperative space with family, trying to optimize patients to better position them so that they maybe are in a safer position to go home and have a speedier outcome, and they could be managed with some home services. And so I think that relationship with the hospital and being able to take the preoperative evaluation with the families and the hours that are spent, coordinating care up front can be handed off to the hospital, care team and to the discharge planners there to say, this is kind of our anticipated plan during the hospital and post-acute that we're going to work out for this patient. And I think a tool that Matt is, I think, going to elaborate more on with this technology of Care Mosaic really is a powerful tool and in-depth tool that really is at the heart of this in terms of giving us some background information on the family and where the patient is really functioning and how they can play through this. So a little bit about these processes that we're engineering. Again, it's daunting for some surgeons that feel like they're too busy to jump in and handle all this, but part of this becomes more that there's medical comorbidities that are modifiable. I think the surgeons need to understand that there needs to be a paradigm shift in thinking about how to approach this. We need to surround them with a talented team that can dive into these patients, these risk factors, because as we know, and there's more and more evidence, operating on a patient with 5 or 6 major comorbidities can put them up to a 20-fold increase in terms of complications, infections, readmissions, and problems. And so I think that's the critical zone that we have the power to interface with our primary care colleagues, with our subspecialty consultants like cardiology or neurology, and really take a hard look at people with CHF and people with neurology conditions and all of the issues, whether, as we've noted here in the slide, where we're dealing with paradoxical malnutrition in an obese patient, or diabetes that are not diabetic patients that are suboptimally managed. We just have more and more data on outcomes and improving a result for patient by managing these things up front. I think the attention of patients of some preoperative physical therapy and really saying how much will the arthritis let them improve their strength, range of motion, and their safety at home. Sometimes home visits to look at home safety and what their environment is they're in, and really taking a look at is discharge home going to be realistic, and how can we make that work. The biopsychosocial piece that's really done by our nurses and case managers is critical. I think there's been a lot of good studies over the last 15 years about not patients that are maybe seeing a psychiatrist and have mental health support, but I think there's a lot of patients with anxiety and depression that maybe don't have a great support system at home. They're a little bit more isolated. They come in and we as surgeons are evaluating them in the office. Are we really getting the full understanding of what their home situation is? How independent are they? How fragile are they emotionally? And I think if you spend any time talking to orthopedic surgeons, there's a subgroup of these patients that come in with arthritis, and emotionally, post-operatively, they're hurting, they have pain, they're taking narcotics, they're waiting on their couch for a physical therapist to come by for the 15th time and go over the exercises with them, and they're crying and they're upset because my surgeon didn't tell me it was going to hurt this much. And then that patient shows up in the office with the doctor, and that doctor is wringing his hands saying, oh my gosh, we're really challenged here. What tools do I have to help this patient get through this, and what could I have done preoperatively to better position this patient? So I think this is a important subset of patients that really need to be looked at. So this optimization of this subgroup, the mental health patients, but I think more critically is really the high-risk patients. And I think we historically have operated on these patients that are heart patients or CHF patients or patients with, that are high risk. And I think to step back and really look at the bigger picture and say, when is surgery the correct thing and the safest thing, and at what level do I need to, improve the patient's risk management before I consider surgery. I think the days of the patient walking in and they say, well, doc, I've known you for 2 years. We've had cortisone injections. I've worked on, improving a few things. I'm taking this medication. I'm ready for my surgery. Here's my calendar. Can you get me in next week? And I think that stopping and using the talent and the power of this team to really look at their whole medical and psychosocial history and putting together the right pieces to make sure they have the proper and the safest experience is really the power of this. So this kind of added touches we've seen in our data and our practices we serve, to all of a sudden say this patient, well, your obesity is something that we've kind of tiptoed around. Your primary care doctor really hasn't addressed it at all, but I know there's some safety concerns in terms of, your outcome that we got to work on this weight control thing. And I think the difference between the patient leaving the office upset, crying, saying, my surgeon said I'm too fat for surgery, I think the answer is, no, my surgeon cares about me, wants me to have a good outcome. He gave me some tools and opportunities how to change this for myself. And so those patients aren't leaving the practice. Those patients are being improved with regard to care so they can have a safer outcome. But I think these type of encounters and using a team that this kind of a program allows the practices the wherewithal to have this RN caseworker, the talented support, puts them in a position they're basically building a concierge type practice for arthroplasty. This gives more of a seamless approach to the care. We know historically the transitions of care into the hospital, out of the hospital, to a skilled nursing center, and then ultimately home. All of these happened before, and a big share of the time, I can say for a lot of surgeons in my practice, they never knew what nursing home the patient went to, how long they were there. They were basically on a need-to-know basis if there was a problem. And if there was issues, they'd ultimately hear about it. And I think what we have in place now is telephonically to use some technology and to have these interactions with caseworkers. We know about the angry, inflamed knee wound earlier, way earlier, before there's drainage and there's infection, and we want to know about it. And we know from looking at our performance of our practices around the country that not just basically operating on the patient, they go off to a skilled nursing unit and they show up for follow-up in 3 weeks. You know, wait a minute, what happened to the patient? What were the circumstances? That's where you get into trouble with bad outcomes. And so I think having the network and a way to track patients and where they're doing, and immediately early on, some practices have implemented earlier follow-up after surgery, maybe 7 days, maybe 10 days. They're looking at these patients, pulling them out of skilled nursing, see how their progress is, making sure the skilled nursing is really performing at a high level, offering great services to the patient. Maybe they're ready to go home at that point. And so I think that there's lessons learned that we've gained from the practices that we've worked, and we share that best practice evidence with the teams that we're working with. So I think these changes, I think a lot of people are looking at opportunities to improve their preoperative teaching, improve their patient information manual to reflect this relationship that we want to be called first after an operation. If there's a problem, we just don't want you going to emergency room and a patient you know, being upset about something they're seeing, and the first step is to go to the emergency room. We want to be called. We have techniques and strategy how to, you know, create that bond, and I think that is really great the way that our caseworkers work with regard to building and sustaining that relationship. We talked about prehab. More and more we've seen hip replacement patients that really use the program, I think, first laid out by the Rothman Clinic in terms of using a walking program for postoperative hip convalescence. So I think there's a lot of things changing and happening, and best practices are going to be a great resource to continue to monitor those and see about where we go in terms of postoperative care and continue to strive for ideal outcome.
Thank you, Dr. Tessier. So as Dr. Tessier spoke about the clinical aspects of this program and how things that you need to do to be successful, one of the other, as I spoke about buzzwords earlier in healthcare, one of the other buzzwords in healthcare recently is big data. And data itself, especially for physicians, clinicians who haven't really had the opportunity to take a look at their historical performance and data in these type of settings prior, it can be an overwhelming process when you start looking at a data set. When we started this program, we found that there was just really not an ideal analytics platform that existed years ago that was designed specifically around care transitions and the use of the case manager to be able to function and perform an episodic transition successfully, that also integrated a dual-facing platform that allowed for the analytics of an administrator or a financial analyst to be able to dig in and determine, you know, where do you have areas of opportunity to improve process to take on a program like this to be successful. So in-house, we had our development team formulate a care transition platform that was going to be dual-facing based on input we received from the care coordinators that were working on the program, the physicians that were engaged in the program, and the administrators to come up with Care Mosaic. We were proud to say that Care Mosaic was the 2017 winner of the Decision Health Platinum Award for IT systems that support care transitions. And the next couple of slides are just going to show some examples of Care Mosaic. And when you're looking at data, there are things around a software platform that you really want to have at your fingertips in order to be able to function successfully and handle care transition and analytics. And you can see on this program, you want to be able to have and work and let your case management staff use a program that really meets them where they are as a practice. You really want to have a lot of flexibility when it comes to customization and being able to drive care transition and care redesign. So in order to do that, we designed a system that has customizable filters, flags. This screen that you're seeing today has everything from care plan transitions. You're able to do the pre-op risk assessment. You're able to take a look and see where patients are in real time, where they're currently at in their process of their 90-day episode. We really wanted to design a system that allowed the case management staff to work with patients both preoperatively through the transition of care process, integrate with organizations along the way, such as hospitals and skilled nursing providers, and downstream home health organizations, PT organizations, to be able to make sure that as a care transition unit, we function and integrate together in order to move the patient through the continuum of care based on their agreed upon care plan with their physician preoperatively. Like I mentioned earlier, Care Mosaic was really designed as a dual-facing platform, because the other aspect of this is you really need to have a handle on where your performance lies and what are the important metrics when you're looking at a bundle payment program and understanding your analytics. So you want to be able to use a software platform that is easy to be able to have someone who is proficient with data and wants to dig into a granular level and drill down and customize reports, or you want to have someone who's maybe not as familiar with that and just wants to see a high-level sort of view. You really want to find a care transition platform that fits both of those sort of users, allowing them to come together and really understand where there are opportunities. One of the things that we've done with Care Mosaic is create somewhat of a matching program that allows us to take the data that is entered from the care navigators that are using the care transition side of the software, and then take the financial data that comes in from the commercial payers or from Medicare on a monthly and quarterly basis, and really pair those sets of data up to look for workflow gaps and allow our team to work with your staff to identify areas of opportunity to improve processes and really create areas of opportunity for patients to have improved outcomes based on what the data is telling us. There's also, you really want to be able to have customizable reports that are visually appealing to the physicians. I know, in starting and doing this program, I have a teenager at home. I know some of you probably do too. And the time that they want to spend listening to us at times, they want everything in their hand, everything easy to view, everything right on the spot. And physicians today are like that also. They really want to have data at their fingertips that they can view on a mobile device, that is fed to them, that they don't have to do a lot of filtering, a lot of customizing themselves in order to get to that. So in Care Mosaic, we really wanted to design reports that could be set up and in the future auto-generated out to those particular physicians. So at any point in time, they could get a monthly report designed, set up, and then automated and sent out to their mobile device in a PDF format that lets them be able to take a look at where they are historically, how they're trending in the key metrics that are important to whatever clinical episodes they're managing at the time. We also have a mobile solution. Care Mosaic Mobile was really designed with the physician in mind in order to be able to put patients on their mobile device and let them see in real time where all of their patients that were in the bundle currently are. And I'm going to turn it back over to Dr. Tessier now so he can talk about his experience and how he would use a mobile solution in a bundle payment program.
Well, I would say that as we culturally have started paying more and more attention to these processes preoperatively and trying to effectively, communicate with the folks at the hospital in terms of what to expect and getting the patient to the preoperative clearance, I think with the anesthesiologist in that process, this has become something we're starting to do more and more for all of our patients. But I think when I walk into today at 1 o'clock, I've got a surgery, I'm going to walk into that preoperative room at the hospital, and there may be family members there that I've never met. I've been meeting with maybe a main family member that I'm hoping is going to be a kind of a companion for my joint patient, and this is her husband in this case. Great guy. I've known these people for 10 years. And I'm on the same page with him and the patient. But I want to know, I can pull up in this app and kind of see what our discussions with Carol have been and what the plan is for her post-acute care, and that her husband's available, and what her, whether she's green, yellow, or red with regard to her comorbidities and what some of the issues are. And it gives me, the case manager gives me a summary of the remarks and conversation. I can have that in my phone. I think we've all been in a situation where we thought we had things set up. They were going to go for the patient what we wanted, and our hope was we're going to go home and have this be a experience at home that we thought was going to be most ideal. And all of a sudden, the brother-in-law from Kansas City shows up, and first thing he says when he meets us, well, I want my mom to go to a rehab center for a month because we're all going to Florida. And the reality is, to go through and have those conversations, at this point in time, I want to know what I've said to the patient pre-op, what we have set up with regard to expectations. And this mobile app with Care Mosaic really allows me to know where I am, who's in this bundle right now, who's not, what I've said to who, and what our case managers have said, so we know, what we're going to do and follow through when we start dealing with the hospital, and what kind of messaging was sent to the hospital case worker and discharge planner, so they've already known that the process is in place and what to expect. So that mobility of that, having it in the phone, is a great, it's a valuable tool.
Thank you, Dr. Tessier. Next, one of the things that we really wanted to do is show the effects of Care Redesign and a program like this and what's really achievable in an episode of care. You can see on the screen right now a case study, which was an actual episode that was pre-BPCI with one of the episode initiators that we convened for. And there you can see all of the different areas of cost that make up a total joint replacement surgery that was not performed in a bundle payment initiative. Everything from the acute care setting, which is static, the physician fee, which is static in a bundle payment program. But then you get into other areas that are areas where you can look at customizing a program based on a patient's needs and getting rid of some of the unnecessary overutilization. So you can see in this scenario, as the patient would move through the continuum of care, the total 90-day cost of this episode was over $30,000. Taking analytics, taking the Care Redesign strategies from that Dr. Tessier spoke about earlier, and really buying in and looking at areas of opportunity, as you can see, Care Redesign, you're able to achieve the same total joint replacement surgery, managing a patient through the episode by customizing a care plan. And you can see that the pre-bundle testing, the acute care, the DRG cost, the physician fee, the DME, all of those things stayed static. But the overall cost of the episode was dramatically lower. This particular example came in at around $17,000, which is a huge savings to both Medicare and to the system itself.
I think the great news about something like this and the patient satisfaction and their perception in the family about the outcome and the interaction was a total upgrade from what it used to be with the practice.
Yeah, and as we move, I want to be respectful of everyone's time today and allow for questions. So we did want to get into a few details around the BPCI Advanced program that CMS has made available to date. There'll be details here on the screen, and I believe that the slides will be available afterwards, as well as you'll be provided with the contact information of Dr. Tessier and myself. If you have further questions around BPCI Advanced, you're more than welcome to reach out to any of us. But you can see that in the BPCI Advanced program, it's going to be a retrospective model, similar to the way that the first program was designed. Participants can be acute care hospitals or physician group practices. There will be a historical baseline period that will be taken into consideration in the target price methodology that will be specific to each acute hospital that the case is performed in. Reconciliations will be performed on a semi-annual basis, and similar to the first program, there's going to be a large quality measure component to this that is going to allow BPCI Advanced to have members qualify for an advanced APM. The timeline to be aware of when you're looking at if you're going to possibly participate in BPCI Advanced, the deadline at this point is very compressed, but it's still very achievable at the same time. By March 12th, you just need to submit an application, either as an episode initiator on your own or under a convening organization, to have them request your historical data and acknowledge that you would like to participate in the program. From there, in May, CMS will release the historical data and target prices will be provided prospectively to all potential participants. Each participant will then have 2 months to review that information and determine if they would like to move forward in BPCI or if they would like to postpone that participation until a later date. You do not have to commit to participating in the program by March 12th. You just have to commit to having intent with your data pulled, and then you can make the decision on if it looks like there's going to be opportunity for you. The start date is October 1st of this year, and the next opportunity to participate is not until January 1st of 2020. The program will then run through December 31st of 2023, and one detail to keep in mind is if you do enter into BPCI Advanced in October of this year, you are not able to withdraw or remove clinical episodes until the January 1st, 2020 deadline, when you could then make changes to your clinical episode selection or your participation in general. Finally, one of the things that we wanted to leave you with today before we address any questions that you may have is just really, what does it take to be successful in this program? What differentiates one organization from another? And I think as one of the original conveners participating in this program, it really is a comprehensive approach to care redesign. Everything from the strategic planning and the implementation stage through the clinical coordination, putting together a post-acute care network in correlation with your convener or your partners in your community to really align vision and be able to put together a program that individualizes care of each beneficiary and meets them where they are in their health journey. You really need to have strong analytics and reporting at your fingertips to be able to gauge your performance along the way, understand your opportunity initially, and then use that analytics to to look at what story that data is telling you. How can you look at areas of improvement based on gaps in processes, overlook structural components of a relationship in your community? Look at areas where communication breakdowns have happened historically between providers to try and align those providers together to create a vision and a path for a beneficiary that gives them a better outcome and reduces their cost. Finally, you really want to work with a provider who has a strong advocacy relationship. Here at Signature, we have developed a strong relationship with both the internal department in the Innovation Center at CMS, but also with AAOS and AAOE and all of the physicians that participate in ACUS. We really try to align our vision as a physician-owned and led organization to keep that at the forefront of what we do. The team here really designed a program that was built around patient and clinical based evidence that really puts the physician and the patient in the forefront. And the advocacy work that we do here really is designed to keep the beneficiary in mind, but also keep physicians and providers as the main components who have the most control over healthcare to be able to continue to advance and own the bundle. Now we're going to allow, I think we have a few minutes left for questions.
Yes, so thank you, Dr. Tessier and Matt, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. And it looks like we have time for at least a few questions today, so I'll go ahead and start with one of the questions that already came in, and that is, did you develop a co-management and risk-sharing strategy with other teams, such as hospitalists, to manage comorbidities?
Yeah, so that's a really good question. Yeah, so in this program, you are able to set up downstream NIPRA share and gain share programs with hospitals to help engage in that participation. So one of the things that we've done is we've engaged in internal cost savings programs with over 80 hospitals that our physicians work in, where they're able to align incentives to reduce costs on things in the acute care settings, such as implants, surgical, anything that's used in the surgery itself, in order to come up with a shared savings program on those. There are waivers in place that CMS has put in to allow for those programs, those ICS programs, to be put in place. We've also engaged, as Dr. Tessier talked about earlier, in the preoperative phase, where we're looking to optimize patients, we've engaged those primary care providers. We've worked with the hospital to do co-joint classes, where in the past, maybe the patient would just go to the joint class that the hospital would put on, and there really was a little bit of a disconnect with what their individual physician was telling them. So we've tried to align those sort of initiatives in the individual markets to better, kind of strategize and come up with how we can work together to give the patient a better experience.
Matt, I just add this. I think that there are some practices around the country when the orthopedic team, when they're a hospital-owned, integrated providers, the ability to use the hospitalist internal medicine team and create a preoperative set of specialists that are seeing every patient preoperatively, and literally they're plugged in as with part of this evaluation up front, then it's an obvious extension of their talent that they can follow the patient through the hospitalization, manage any perioperative problems, and they're familiar and have met the patient beforehand. We here in St. Louis, in our particular situation, most of our hospitals, I don't think that there is a preoperative hospitalist clinic that we can send the patient to for perioperative, management of a nutritional deficiency or preoperative anemia, or those things all kind of fall in our lap to coordinate with their family practice doctor, their primary care doctor, or whatever. So I think that's a tremendous opportunity to be able to have the structure, obviously working with the hospital. If you can have preoperative hospitalists working that are going to stay on the case during the hospitalization, I think that's powerful. It's great. We haven't done it here. I know some places have and been very successful with that. Should we go to another one?
Absolutely. It looks like we have time for one more question. And that question is, how do you address the high cost of implants? If we can negotiate the total knee that costs $4,500 down to $2,500, how does that impact the bundle payment?
Okay, so that's a good question. So in the current program of BPCI, as well as in the CJR program, which is the mandatory program from CMS, and then the new BPCI Advanced Initiative, there's a DRG payment cost that is built into the target price. So in a hospital setting, for a total joint replacement, let's just say, the cost of the implant, all of that is included into the DRG payment with the hospital. So that, whatever the hospital's DRG payment is from CMS, that's a fixed cost. It's part of the target price and your historical individual price that you'll get at a hospital level. Where you can look at reducing the cost of the implant and how that would affect things is where you could set up a gain share model like we spoke about before, where it's mutually beneficial to look at streamlining costs and processes in the acute stay. So there will be waivers in place in the next program, as in the current program, where you as a physician organization can look to work with going to a single source implant or looking to reduce those implant costs and share that savings with the hospital in order to recoup some of those funds, and that's part of an incentive that would be available to participating in the program. And I don't know, Dr. Tessier, from a physician's perspective, if that's something that you have any more insight that you'd like to comment on?
Well, I think this is something that's really done, even though we have several practices that have developed gain sharing relationships with the hospital. I think this is something that is key, that orthopedic department who's performing these cases, those doctors really, sit down and are leading that, dialogue with them. We have some people that we collaborate with to help with that, correct? But my point is that decision about going to a dual vendor, single vendor, who's comfortable with what, that's really, the rubber on the road are the surgeons putting the implants in, and changing instruments and implants is it creates a lot of issues that you have to be very careful of. And so that's really something that should be decided on the surgeon level.
Well, thank you both for your insight on that question. This concludes today's program, but I want to thank Matt and Dr. Tessier for their excellent presentation and to our audience for participating. Enjoy the rest of your day, and we look forward to having you join us for future webinars.